766, we are live. We are continuing 766, our kind of jurisdiction here. I still think this is an insurance regulation, not healthcare bill, but our concern would be impact on insurance rates. We've worked for 2 decades to get them, to keep them down, and to have as many people in this state insured as is humanly possible, and I would hate to see us start to backslide on that, because I think we know the 16+% increase in health insurance in schools was a major cost driver in this year's budgets, and insurance may be great, but if people can't afford it, it doesn't do them much good. So that's the balance between good care and affordability. And our first witness is Dr. Faye Holman. And okay, Dr. Holman, just introduce yourself to the record. Welcome to Senate Finance, and the floor is yours.
Thank you. Thank you very much for having me today. I'm Faye Holman. I'm a family physician at Little Rivers Healthcare in Wells River. But I'm speaking as a member of the Green Mountain Care Board's Primary Care Advisory Group, which I'll refer to as PCAG. We're a diverse group of 16 primary care providers from across the state, private practices, FQHCs, and hospital-owned practices. We are doctors and nurse practitioners, family physicians, pediatricians, and geriatricians. I mention this because my testimony is not an individual with a gripe, but rather a group of stories from practices across the state in primary care. PCAG has made decreasing the burden of prior authorizations a priority since its inception in 2016. In my testimony today, I'll be giving you specific examples from members of PCAG about the cost and harms that are caused by prior authorizations. I'm including step therapy when I refer to prior authorizations. I'm including step therapy in there from a practical standpoint for what our staff members have to do for authorization of these. The steps are very similar. We urge you to support H766 as it's written. It's a bill that stands to improve multiple critical issues in primary care, including patient access, patient outcomes, high cost, fragile primary care infrastructure, workforce shortage, and professional burnout. Insurance companies will tell you that they save money on prior authorizations, but they do so on the backs of already overburdened primary care practices. I work at Little Rivers, an FQHC serving Upper Valley, Orange, and Caledonia counties. At our Wells River Clinic site, we have one full-time staff member who works solely on prior authorizations for 4 providers. Estimates from other PCAG members are similar. 1 employee working on PAs for every 4 to 6 providers. This is financially draining and decreases patient access to care. Think for a moment what we might be able to accomplish in expanding meaningful primary care if our nurses could spend their whole days on the telephone with actual patients, such as regular calls to our patients who use the emergency room frequently, or to educate our newly diagnosed diabetics. Prior authorizations cause real harm to patients. Some stories from PCAG members. I am currently caring for a 21-year-old with an unintended pregnancy, which occurred when she missed several days of her birth control while waiting for a PA to come through. Another story. I recently cared for a cancer patient who, due to bowel damage from radiation therapy, was unable to absorb oral pain medications, and so she used a topical narcotic patch. During her terminal illness, there were 2 week-long delays in getting the PA for the patch. We were told that further clinical information was required, even though the rationale was clearly outlined in our office notes. We were told our faxes hadn't come through, even though they were documented as successfully sent in our system. We were told that the appeals window had closed and we had to reapply. Twice, her husband had to pay hundreds of dollars out of pocket so that she could have end-of-life pain relief and avoid narcotic withdrawal. Another story. A patient's insurance stopped covering her asthma inhaler, which had been working well. She had an adverse reaction to the new inhaler, progressive worsening of her asthma, and required hospitalization. Subsequently, multiple PAs for alternative inhalers were denied. The appeals rep wouldn't accept a verbal appeal and sent yet another form to fill out. We're still waiting for a response 2 weeks later. Another story. I have an 11-year-old patient with such severe behavioral problems that he cannot safely be in school without his medication. He's had a remarkable, sustained response to medication, which allows him to attend school and learn. His mother changed insurance and they won't cover the medication unless he has tried and failed 2 other medications. Think of the repercussions for this child, his education, his school, and his mother during this trial. This is an example of clear patient harm if he is forced to go through the step therapy process. Prior authorizations increase costs and decrease access to primary care. Insurers will tell you that PAs are done within 48 hours and call wait times are less than 8 minutes. If you're inclined to believe them, the members of PCAG invite you to spend a day in our clinics. Here are some of our experiences. We're often told we'll get a call back and don't. This happened when the insurance company phone recording warned of 1-hour wait times. It has happened during scheduled peer-to-peer consults. That's the last step in the process where the prescribing provider gets on the phone with the insurance company physician. And it's happened to not get a call back even when times like that were scheduled. Another quote, often the insurance company provider on peer-to-peer calls hasn't even read the clinical note outlining our rationale for the needed testing. We have filled out forms, faxed documentation, and clinical notes, and the insurance company's decision maker hasn't even looked at it. Another quote, our staff has been on hold for an hour simply to ask if a prior authorization is needed. When looking into a delay on a PA, we were told that we'd faxed the appeal to the wrong number, even though it was the one on the denial form. Many PCAG members say that they have sent patients to the emergency room or to specialists in order to get testing done. An example is a child with head trauma who needed a head CT. Delay in prior auth caused the pediatrician to send the child to the emergency room. Delays caused by PAs are common with antibiotic, cardiac, and asthma meds, which are time-sensitive medications in preventing emergency visits, hospitalizations, and patient harm. 2 PCAG members have had patients require hospitalization because of delays in getting home oxygen approved. It's important to point out that the PA process feels irrational and burdensome. It contributes to professional burnout. Our members say this, PAs feel like a game of trying to use the correct language that the insurance company prefers. Many denials are not about clinical judgment, but about technicalities in the ordering process that lead to initial denials and delay medical care. Another quote, the greatest frustration is that there is no access to the actual criteria used to cover tests or medications. My staff will sometimes answer questions in all different ways on the online system to try to discover what might result in coverage. PCAG members report having specialists tell patients to ask their primary care provider to order certain tests that require PA, thus offloading the PA burden onto primary care. A recent example is a cardiologist recommending sleep apnea testing, but telling the patient to ask the primary care provider to order it. The PA burden then becomes unpaid work for the PCP. Another story, we had denial of 4 birth control prescriptions in a row for a 17-year-old. There was no list of covered birth control pills on the insurer's website. We just had to keep putting in different prescriptions until one was covered. Even when the system works as the insurers claim, with 8-minute call times and 48-hour turnaround, it is a nonstop administrative burden for our staffs. More than 90% of PAs ultimately are approved, which only adds to the absurdity of the workload. I have included in my documents a document by one of our nurses about a 4-month effort to get an MRI approved. It has the benefit of being in the voice of the nurse who spent her days working on it and clearly documents the incessant roadblocks. I hope you'll take the time to read it. I understand that insurers are asking to strike the language that would allow patients who are stable to be exempt from PAs for 5 years. They say this allows the patient's time to be clinically evaluated for more appropriate therapy. Clinical evaluation is the primary care providers and prescribing providers charge, not the insurers. We see our patients regularly, and we must renew prescriptions at least annually. So please allow the current language in H766 to stand and thus lessen our PA workload. The term moral injury is increasingly used in studies of provider burnout. It refers to the psychological toll taken of taking part in actions that go against the clinician's morals and values. We know what our patients need, and we are unable to provide it. Practicing medicine in this setting contributes to professional burnout. We know that you as legislators are well aware of the recurring issues in today's challenging healthcare scene: patient access, patient outcomes, high cost, fragile primary care infrastructure, workforce shortage, and burnout. H766 plays a role in addressing all of these. We urge you to provide your full support. Many thanks for your attention today and for your dedication to improving healthcare in Vermont. And I'm able to stay for questions if anyone has any.
Okay, thank you. Senator Bray.
Thank you for joining us. Just a quick question. Sometimes I hear people, they ask me the question, and obviously I don't know the answer, but it's because it relates to practice. And the concern I've heard some folks share was that because pharmaceutical companies will do marketing and outreach directly to physicians, that physicians might be more apt to prescribe brand names rather than generics, and that brand names could drive costs high. So can you just speak to how physicians make those sorts of choices, and if to any degree, cost comes into your thinking when you're making the choices about what medication?
Yes, thank you. That's a really good question. And there are some challenges with the direct marketing to patients. Oftentimes patients come in with a very clear idea of what medicine they want because they've seen it on television, and there are much cheaper alternatives. I will say that I think keeping the cost down for patients is something we think about every day, every prescription we write. So many people, the vast majority, really are underinsured at this point with huge deductibles. I recently talked to a patient with a $10,000 deductible. That was the highest one I've heard of, but many of us, even in our office, have $4,000 deductibles. So we're thinking about those cheaper generic medications with every script that we write. And I think you would find, if it were studied, that we very rarely use unnecessary brand name only medications.
Thanks so much.
Are you seeing patients that are struggling or do not have health insurance?
Yes, absolutely. We, as a federally qualified health center where I work, we take all comers regardless of ability to pay, and we do have a sliding fee scale, but we have care coordinators here who work with people probably on a daily or certainly several times a week basis who have no insurance at all. There are a lot of different reasons for that. Some are people new to the state. Some are people who truly cannot afford the premiums that are suggested on the exchange. So yes, it's very common.
I think that's the balance we're trying to get to, so. Senator Fawns.
Several years ago, the focus of the legislature was on the excessive and maybe irresponsible use of pain medication and it leading to, addiction off the issue of the health problem that caused it in the first place. I've had some anxiety at the time and now that I worry that I'm hoping that we don't go overboard on that. Is this sometimes someone watching out to make sure that you're not over prescribing pain medication?
Complicated question. Here at Little Rivers at our FQHC, we have a very robust MAT program or Suboxone program. Our community has been very hard hit by the opioid epidemic. And I think what's happened with us over time is that we try more and more to not prescribe narcotics, and we're amazed at how well it works. That people really can get excellent pain relief using combinations of non-narcotic medications. And so within our practice, we do kind of do printouts of providers' prescribing habits, and we do work with people who are high narcotic prescribers to try to diminish that. The question of have we gone so far that people can't get pain relief? I don't think so. I don't see a lot of evidence of that in my practice. And I think on the whole, the world is a lot better off with not having as many narcotic prescriptions rolling around and sitting in people's cabinets and available for misuse. Did that answer your question?
Well, I wasn't really asking about prescribers, but rather the insurance companies. Are they fearful that you're overprescribing?
I would say I might have a different answer if I had time to think about that, but at this moment, I don't think that there's a lot of, I don't get any feedback from insurance companies about narcotic prescriptions specifically. The limitations on that really comes from the Vermont laws that were passed in the last few years. We occasionally will get communications from insurance companies about prescriptions that people have been on for a long time. Do they need to be on this still? But I have not perceived that as too much of a way of trying to control what we're doing. And I don't see that as a big problem.
Thank you.
Okay, I'm gonna have to move this along. So, Dr. Holman, thank you. This has been very helpful. Erica Brown is there. Erica, the next witness has a hard stop at 3. I can take him now and then I won't be saying in 15 minutes that I've got to cut you off. Does that work for you?
Yes, that's fine.
Okay, so I've got Rick Dooley next. And I really would prefer you didn't take the half hour, because we started about 45 minutes behind. So we have a full room here. It's a busy afternoon. So Mr. Dooley, the floor is yours. Just introduce yourself for the record.
Certainly. So my name is Rick Dooley. I am a full-time family practice PA at Thomas Chittenden Health Center in Williston. And in addition, I'm also the clinical network director for Health First, which is an independent practice association that represents both primary care and specialty practices, independent practices across the state. And I'd like to thank the Senate Finance Committee for the opportunity to talk about Bill H766 with you. I'd like to tell you a little bit about my practice in Williston. I promise I will not take the whole half hour. I'd like to I'll tell you about my practice in Williston. We're a family practice serving approximately 13 to 15,000 patients. We have a full service clinic, including 12 full-time equivalent primary care providers with associated clinical and non-clinical staff. In fact, we have almost 3 staff members for every 1 primary care provider. Some of our other Health First practices have as many as 4 staff members per PCP. One of the large reasons for the expansive non-clinical staff is administrative burden around things like prior authorizations, in addition to payment processing, insurance requirements, audits, and reporting. We appreciate the efforts of the legislature to address some of this burden with this bill. Now, as has been stated in previous testimony that I'm sure you've heard from lots of folks by now, the burden of prior authorizations is crushing. It's not unusual for a nurse or medical assistant to spend 45 minutes to an hour on hold on the phone trying to get a single prior auth approved. My nurse spends probably an average of 2 to 3 hours a day working on prior authorizations in between rooming patients and taking calls. This bill looks to reduce the number of prior authorizations required by modifying something called step therapy, where an insurer has specific medication trial requirements before paying for another medication. One of the most important pieces of this legislation is the inclusion of drugs within the same class as part of the step therapy protocol, which allows for greater autonomy for the provider to choose the most appropriate medication. In addition, this legislation allows for patients to continue a medication that's working for them even if the formulary changes. And I have actually one patient example that encompasses both of these issues. I had a male patient, a gentleman in his early 60s, who has a history of familial hyperlipidemia, meaning he had high cholesterol as a result of his genetics and his parents, essentially. For those who know your cholesterol numbers, which a lot of people do, his were super high. His total cholesterol is well over 300. He had an LDL, or bad cholesterol, of well over 200. A strong family history for heart disease in both his father and his grandfather. So these are folks who absolutely need to have treatment, or they risk having a heart attack or a stroke. Over the years, he's been on multiple cholesterol medications in the past, including lots of statins, and he couldn't tolerate them because he would get these severe debilitating muscle aches that would prevent him from working. This is a class effect of statins, and it does happen in some folks. That's why people don't tolerate them sometimes. There's a newer injectable agent available that is indicated exactly for these folks with very high cholesterol with associated risk factors. Unfortunately, it also is much more expensive than statins, and insurance companies don't like to pay for it. First, they denied it because he hadn't had a cardiology consult to determine his need for the medication. So I referred him to cardiology. Cardiology agreed that that was the most appropriate medication for him and sent him back to me and asked me to prescribe it, I think because they probably didn't want to go through the prior authorization themselves. So I then did the prior authorization. I got a 9-page questionnaire back, literally 9 pages, going through every medication he'd ever been on. So I spent probably the better part of an hour going through his chart, documenting every previous medication I could find, even ones from his providers before he saw me, including 3 other statins he had been on. They then denied the prior authorization because they said that he needed to fail 2 additional statins, the same medication that gave him those severe debilitating muscle aches. He needed to try 2 more before they would consider approving it. After that, I obtained a peer-to-peer where you could speak with a clinician directly at the insurance company, and the medication was approved finally for 5 months. At the end of 5 months, it was the start of 2024, and the formulary changed, and then the medication was no longer covered. There was a second injectable medication that is also in the same class that is appropriate for him. We weren't sure how he would react to it. He had responded well to the first one, so I prescribed the second one so we could try it, and then got another 9-page prior authorization form back to prior auth the second medication in the same class as the one they had just paid for the previous year. The end result was that he actually went off his medications for 3 months until we could get the second prior authorization done and approved. The whole process probably took 3 to 4 hours of my nurse's time, at least an hour to hour and a half of my clinical time, and an unnecessary cardiology consult, all literally for medication that best medical practice clearly states is the next step for him. With regard to prior authorizations for procedures or therapies, there are several particularly frustrating aspects. One issue is the arbitrary time frame around approvals. Often imaging or treatment facilities won't schedule an appointment until the prior authorization is approved. My scheduling staff will work diligently to complete the paperwork and get the approval, which is given for a specific site within a specific time frame. They go to schedule a patient, and oftentimes the appointment will then fall outside of that time frame. When that happens, the prior authorization is then no good, and they need to call to modify the prior authorization and take more time off their schedule to do that. Furthermore, it's only approved for a specific facility. So if they get approved for, say, UVMMC, and then the patient says, well, I can't wait that long, but I can get it done at Copley sooner, we then need to do another prior authorization for the Copley site. In terms of ongoing therapies, the requirement to complete additional prior authorizations for therapies that patients have been undergoing is just ridiculous. I have a middle-aged woman with a history of sleep apnea, confirmed by sleep study last year, started on CPAP therapy, which most people know, where the Darth Vader mask there, and it works great. You get a good night's sleep. So she started on it, worked incredibly well for her. As winter approached, she had a bit of an emotional crisis. She had a life partner who passed away. She was emotionally pretty distraught. She decided to do some traveling. She bought a travel CPAP machine off Amazon, her own money, because CPAP worked so well for her, and then spent some time traveling over the winter. At the start of the new year, the insurer refused to continue paying for her previous CPAP machine because they said that she hadn't been compliant with the previous one. So she called them up and said, here's the deal. I was traveling. I have my own CPAP machine. They would not take her word for it. They said that I need to do a prior authorization and state that she had her own CPAP travel machine, and that's why it was not compliant. Now, something that I presume she's telling me the truth, but she certainly knows better than I did the peer-to-peer, explained what was going on. They still refused to cover it until I saw her as an office visit to confirm that she was in fact not using her CPAP machine because she was using a sleep one, a travel one rather. In addition, when they call me for the peer-to-peer, it was kind of like when the cable guy says he's coming between 8 and 4. They said, we need to do this peer-to-peer. You let us know what half hour you can set aside next week sometime between the hours of 8 and 5, and we'll call you sometime within that half hour. So I had to set aside a half hour of patient time at a time when Access is already at a premium to literally sit and wait for the phone to ring so I could answer questions about a prior authorization that was completely unnecessary. Many of these prior authorizations that we're doing now are just ridiculous. Before I got on this call, literally 10 minutes earlier, my nurse came to me because I prescribed tizanidine, which is a generic muscle relaxer that's been out for decades. It costs $7.58, and we have to do a prior authorization form for it. $7.58 generic medication. These are barriers for patients who, if anything, they're often going to end up paying out of pocket despite having insurance because they can't afford to not have the medication. At lunchtime, I was on a call with the gastroenterology practice who noted that some insurers require prior authorization for propofol sedation for colonoscopy, even though that is the safest and most effective way to do the procedure, with much greater patient satisfaction than either conscious sedation or general anesthesia. A sports medicine practice we work with has seen the same things with Euflexin and Synvis for joint injections. These medications often relieve patients' arthritis symptoms, resulting in improved quality of life and ability to work, yet treatment is often delayed because the practice can't give the shot until they've documented that they've tried 3 other less effective shots and the patient has gone through all this other stuff that may or may not have helped before they'll approve the prior authorization. I could go on and on. There are a million prior authorization horror stories. My last point with prior authorization is that almost all of the time, in most cases I've mentioned, most of the above cases, the prior authorizations are approved. If I'm ordering a medication for a patient, I can justify its need. If I'm ordering an imaging study or a therapy, it's generally because it's medically necessary and appropriate. I don't need the insurance company to tell me this is not the right study for this. That's what the radiology department's job is for. They will call and say, hey, I see that you ordered a CT of the abdomen. We think we'd get a better look with X. And then that's what we order. Those are the people who should be making these decisions, not the insurance company. The issue is not that these items are not getting approved, is that we're dedicating tremendous amounts of staff and provider time to comb through charts, complete forms, schedule peer-to-peer reviews, and write letters of justification just to get the service that we all know is medically appropriate. On top of that, prior authorizations vary by insurer, and there's often inconsistency even between different plans within the same insurer. So oftentimes the medication that's approved by one Blue Cross plan is denied by a different Blue Cross plan. So it is impossible for us to keep track of what's current and what's not. I understand the insurance company is concerned about the increased risk of the increased cost rather. But the reality is that there are costs to our current system, both financial and in terms of health risk. And those costs are currently being borne by the rest of the healthcare system and patients themselves, not by the insurance companies. H766 will certainly not eliminate all of our administrative burden from the backs of primary care providers, but it's a step in the right direction. It gives healthcare providers the tools they need to provide better care for patients while still allowing insurers some cost control. It helps reduce some of the administrative burden, which will make it easier to recruit new providers into primary care and strengthen the primary care foundation. This is the right decision for Vermonters. Again, I appreciate your time and I'm happy to answer any questions.
Okay, Senator Gray.
Thank you for your testimony, Dr. Dooley. When you have a quote unquote peer-to-peer consultation, is that with a physician? With whom are you speaking on the other end generally?
It can vary. Sometimes it's a physician, sometimes it's a nurse manager, sometimes a nurse.
Okay. And if you had to guesstimate your batting average for how often the requests for any particular medication are approved, is it 80%, 90%, 99%?
I would say if it goes to a peer-to-peer, probably 98 to 99%. It's very seldom that and the ones that have that generally don't get approved are because as I'm talking through, it's sort of one of those, well, we could do this or we could do that, and we go back and forth, and I order one study and the insurance says no, we'll pay for the other one. But yeah, generally it's about 98 to 99%. If we put forth the effort, generally we can get things approved. It just takes us a lot of time and effort to do that.
Sure. And you mentioned some frustrating stories with things lapsing in some way or another. How often are most authorizations time limited, or once the medication's approved, someone could be on it for years? I'm just wondering if the time limited things you've been bringing up are unusual, or that's
No, they are by far the norm. Medications are generally approved. The sort of the standing joke is we all start cringing January 1st because two things happen. One is prior authorizations expire, and so you need to redo prior authorizations from the previous year. And the second is that all the pharmacies change their formularies, and so all of a sudden the med that the patient's been on for 2 years is now suddenly not considered formulary. So you do the prior auth, and then you find out that's not necessarily covered now. Now you need to switch to a different drug within the same class.
Thank you very much.
Okay. Thank you. It's been helpful.
Thank you.
And thank you for got you out before your hard stop.
I appreciate it.
Okay. We appreciate the work you do with the hard stuff. Next, we've got Erica Brown. Erica, same thing, just introduce yourself. The floor is yours.
Thank you. Our CFO, Kyle Munson, was going to just start the introduction, if that's okay, and I'll follow up after him.
Yes, I don't think I have him on my agenda, so yes, this is your time. You can have anyone you want to.
Thank you. Good afternoon. My name is Kyle Munson. I'm the Chief Financial Officer for the Community Health Center here in Burlington, and I would like to thank the committee for allowing me to speak today. CHC currently cares for over 30,000 patients annually, providing medical, dental, counseling, and psychiatric services. On average, we have about 135,000 encounters per year and submitting almost 180,000 primary claims. FQHCs have proven to be very critical in providing high quality primary care services to the community. And in many respects, we are the safety net for the most vulnerable members of the community. FQHCs operate at a very slim margin, and by slim, I mean low single digits. And the cost of multiple edits, resubmissions, and delays in payments can have a very significant negative impact on the center's operations. CHC, like other healthcare providers, and not only in Vermont, but across the country, are dealing with spiraling cost, the cost of people. Approximately 78 cents of every dollar that we spend is on employees and employee benefits. So we are constantly looking for ways to save money and generate a margin to support the mission of the organization. If primary care providers continue to be burdened with administrative tasks, access to care may be a bigger issue and could result in increased ER utilizations instead of having an office visit with their primary care physician at a fraction of the cost. keeping in mind that FQHCs and community health centers are the lowest cost of care in the continuum of medical services. Without access to PCP care, providers cannot enact care coordination to better manage patients' care and services in order to avoid unnecessary medical spend, which in all respects is better for the system and for those that are in the care of the system. I don't want to take up too much time of the committees today, and I would like to thank you again for allowing me to speak. And I would like to turn over any remaining time to Erica to continue in with her testimony.
Okay, so Erica, you're going to continue?
Yes, thank you. My name is Erica Brown. I'm the Director of Patient Accounts for the Community Health Centers. We're, again, a federally qualified health center serving Chittenden and Southern Grand Isle counties. I appreciate your time today. I'm speaking today in favor of Section 2 of the claims processing of Bill H766. My intent is to really summarize the main concerns and their impact on patients, provider offices, and the healthcare system in general. Non-payment and inconsistencies are a very large concern. When the claim editing system was put into place, called Cotiviti, it has caused claims processing time to increase due to manual review, denials, and then manual review of notes in order for payment to occur. These delays in finalization of claims processing can extend 60, 90, or even up to 120 days after data service if an appeal is needed. The work involved in the administrative work involved in handling these denied claims is pretty substantial. It requires separate emails sent to us by the payer, which outlines denials, reasons for denials, coding review, manually sending each chart note visit by visit, patient by patient to a designated email. Honestly, often post-coder review, there is nothing wrong with the charge or claim. The note should substantiate and allow for payment. But again, the administrative burden for us to get to that point is very, very time consuming. There's also inconsistencies in the denials. So sometimes we are paid for one of, say, 2 services. In that same scenario, we're paid for none of the services and it's required for a claim review. So there's a lot of inconsistencies with the denials as well. And then working these denials with varied results or no response back, we're often not getting responses back as well, really makes us have to do the whole process over again, which again continues the length of time it takes to get a final decision from the insurance company on a balances or amount paid. Tracking these claims with the varied responses or no response at all, the varied process and the lack of communication and the need for causes the need for additional follow-up, again, restarting the process. Blue Cross Blue Shield is not our only payer. We do have other payers, so it would be helpful for there to be alignment among payers in order to proactively and efficiently work claims across the board. I'd like to also speak to patient impact with this Cotiviti claims editing system. The delay in payment also does significantly affect the patients. Should the finalization result in a patient balance, the prior physician spoke of high deductible plans, and it can be difficult for patients to budget and pay balances for visits that were rendered 60, 90, or even 120 days ago. If multiple visits finalize at the same time or near the same time, that can be a very large bill for patients to try to pay. Additionally, affecting patients is the delay in claim finalization can result in patients' balance to not be within the time frame that they can actually submit for their HHA to pay the bill. So I'm sorry, the HSA does have deadlines for patients to submit and have them pay for these designated funds to pay for their balance. And if that deadline is missed due to claims processing, the patient misses out on utilizing that bucket of money from HSA to pay the bill. Lastly, I'd like to just speak to staff burnout. We've lost seasons billers with 15+ years of experience, and other seasoned staff just for less stressful jobs like Costco and other non-healthcare positions. So in time when staffing is difficult, this poses another hardship for primary care. The financial burden of non-payment due to inconsistent and unreliable processes is falling upon the provider and at times eventually to the patients. So does anybody have any questions?
I am not seeing any. Thank you. This has been helpful. This is a good balance. Committee, we've only got this, we haven't got the bill. We've got limited amount of time to look at it. I would like to do some committee discussion just to see where we are and if and what we might want to do. But we started way behind and I've got witnesses waiting, so I'm gonna kind of put off committee discussion until at the end of the day, because we've got this one and we have the next one. Senator McDonald, do you have my? Is that right? Okay, so we're going on to
You're right, could have used that.
yeah, we have more witnesses at 3:50, so we'd like to work at getting caught up. We're going to H 657, which is the modernization of Vermont's communications taxes and fees. We have Kim Gates, and Kim is here, is up there. Maybe we have lost him. Did you have any communications with?
No, I came in earlier and there's those posters, which I think are from her behind the chairs, but I haven't
She's
seen her.
not here. You want to see if she's in the hall? That would be great. And if not, we'll go on and she'll show up. She may have shown up and we were missing. No. There she is. Okay, Kim, the floor is yours. Thought maybe you'd given up on us. Because we are way behind schedule. Our floor went long today.
Couple things, thank you very much.
That's not this house is supposed to be.
In the
Some of us have met you. Yes. Back when there was a telecom.
Yeah.
I'll stand, how's that?
Okay.
Okay. I am Kimberly Gates and I'm president of the Telephone Association of Vermont. And so Jonathan doesn't have the whole day lobby. These are just a few of the things my company is doing. So this is our recent fiber build in the populous area. And this is just our family crew that runs it.
Okay, just for those of us who haven't met you before, tell us a little bit about Franklin Telephone.
Yep.
Your size, what you do.
Sure. I'll start out with that. First of all, I'm here for the Telephone Association of Vermont, which is made up of Lindenville, Northfield, Perkinsville telephone companies, which are part of TDS, Shoreham Telephone Company, which is doing business as GoNet Speed, Thompson Telephone Company, Vermont Telephone, known as VTEL, Waitsfield, Champlain Valley Telecom, and Franklin Telephone Company. So I am the controller of Franklin Telephone Company. And that means I like to control everything. So I do a little bit of everything. I do legislative, I do customer service, accounting, tech support, engineering, central office tech, flagging. I do a little bit of everything.
Yeah, but the only thing you don't do is climb the poles and string wire.
I don't find that I run the bucket truck if I have to. So, jack of all trades, master of none. But I'm very familiar with the whole process. We're family owned and operated. The company was started by my great grandfather. So the Farmers Exchange could communicate with the railroad. So that was 130 years ago. Fast forward to today, we serve a little less than 900 customers, 20% are seasonal. We provide fiber to the home. We are a carrier of last resort. And what that means is, when somebody builds in our service area, we have to provide service to them. And provide 911 service. So it's an obligation, there are federal and state obligations to do that. And in return, there have been different caveats, because of that obligation. So we've had fiber optic service started about 10 years ago. And Franklin has an impressive fiber footprint. We're very close to having fiber down every road. Still have to do the drops, which is a drop is the service from the pole to the customer. Aerial drops, I can get it done in a day. An underground drop could take a long time. They're not very in conduit most of the time. Of our year-end customers, 61% are on fiber. That just gives you an idea. We serve a rural, high-cost area. So Franklin Telephone Company is located on the Canadian border, up by Lake Carmine. We serve most of the town of Franklin and a portion of Sheldon and Highgate. So we don't serve an entire one town. It's portions, to downtown Franklin that, populous. Everything is. So we're in a rural, high-cost area. We've been deploying fiber, and we're trying to get all our customers on fiber. It takes time and it takes money, and we're trying to keep rates affordable. So I'm here today on H657. And I just want to focus, the goal for us is to build more broadband and keep services affordable. And this bill H657 has some pretty major tax changes that will affect us, which will affect customers. The main concern is the taxation. So currently, Franklin and Thompson Telephone Company are taxed on an alternative taxation on gross revenue. So what that means is each quarter, calculate our gross revenue, and I write a nice check to the state of Vermont tax department and send them a check. So,
There is an exemption for small carrier.
not to keep, so
This would be the poles and wire taxes.
that's that is for right of way.
Well, the poles and wires are also not in this bill. This expands poles and wires as real property. And puts them on the grand list. Oh, your poles and wires should be on the grand list unless there's an exemption for small carriers that you don't know about.
So there's currently for the Telephone Association of Vermont. Currently, there's this alternative gross revenue tax that Franklin and Thompson Telephone Company have been paying historically. And so that tax is quarterly gross operating revenue. It's a calculation by the Vermont Department of Taxes. And I send them a nice check. I don't pay the property valuation tax on poles and stuff, and I don't pay corporate because I pay this gross revenue. The other companies pay a book value on their inventory,
On
on their
proposals, the
Proposals.
transmission.
yes. This legislation wipes my alternative taxation out. And not only will I have to go from that, I have to do this whole calculation. And it goes to, and the other companies will change from a book value to a fair market value.
Well, and that is going to be done by the state. It's in the miscellaneous tax bill, but the state has hired a lister, an appraiser who specializes in utility transmission appraisal, fair market. And so the poles and wires, if we choose not to continue this exemption, we just heard about it, so.
Yeah.
That, yes, it would be taxed as real property on the town grand list.
Yes, and for the other companies that are used to it, they've always given that information at book value.
Yes,
And the new change is fair market value. Which is, you know, my mind, fair market value only happens when there's a legitimate sale.
yeah. And apparently that is the term that the listers use. We aren't experts, but
Right, so
property valuation tells me that that's what they're doing. And, well, yeah, because you're your own small carrier. It's the major utilities that cross many towns that this won't have an advantage for. It won't have an advantage for you if you're paying on those operations, those.
well, that goes with age 657, that goes away.
Okay. And has anyone talked to you about that before? Okay.
No. So
News. And we have, you said you, Thompson,
just Franklin and Thompson under this.
Franklin and Thompson, okay. We have an exemption for small carriers.
The small carriers is under the right of way section.
Okay,
That's
so you
two
got
separate.
covered there. But, okay,
So this is just how this first part is just how we're taxed.
okay,
So Franklin and Thompson pay the gross revenue to the Vermont Department of Taxes. The other companies submit a valuation on book value for their poles and wires and pay the Vermont Department of Taxes. And they also pay a corporate tax.
right. And that's how we're organized.
That's how it's been. And with this new legislation, throws us all in the same bucket. And instead of using book value, which all the companies have and can document, this is the book value. This is what I paid. This is what I'm doing depreciation. That's what I paid.
I think they may be essentially the same thing, but
Not
it's, everybody praises them a little different.
right. So we're very concerned with, if it said book value.
Yeah.
It's still a huge burden for us, but the book value for the other companies is very important to just say book value. You can document it. It's, you know, you don't have listers trying to guess if it's a fair market value. You have the documentation. This is what I paid for stuff.
Well, this now, in the future, the state is gonna determine the fair market value. And they will give that value to the towns. They've hired a specialized appraiser to do that. So the towns won't have to worry about how you make differentiations. And we'll check on that phrase,
Right. Well,
because we've asked on what basis they're going to
it's,
appraise.
the other concern too, on when you start using fair market value, which is
Yeah.
the language in this bill,
Right,
is the lines that I have in Franklin, are they worth the same fair market value as the lines in Burlington or Rutland or St. John's Berry or Craftsbury or, you know, there's so many unknowns where if book value is documented.
yes, and that's why the state's gonna do it, because the towns that do it have to hire a specialized appraiser. Because listers are not trained, they aren't certified in utility transmission appraisal.
Right.
So there will be a specialist and it will be done according to an official standard. If that's book or fair market, I will check on the wording in the bill.
Fair market.
It is fair market.
Well,
So
it's
the
fair
difference
market value.
between book and fair
Net
market.
book value is the purchase price, the cost, less any depreciation. So it's been significantly depreciated property,
So there's
the telephone, a lot of the telephone property.
So it is going to fair market,
Yeah, and that,
because book is, yeah, you've been doing this for 3 generations, you're pretty depreciated,
Actually, no,
you're not,
I've just built all new fiber plant the last 10 years.
that's right.
And had I put a huge influx of cash in last year.
Have you calculated what the hit might be to you?
No, I did it roughly on book value and it increases my cost, but it's still an unknown,
I don't know, okay,
it's a completely unknown.
we have two small carriers that
And
have been paying,
And I talked to, 2 accountants with other companies this morning, just to verify I understood, and, when you switch from book to fair market, it's all unknown. I did, interesting, I got mail, we used to own the Franklin Electric Light Company, and somehow I got on the tax department mailing for the form that the electric companies fill out. And with electric company, how many miles of distribution, how many
Yeah.
transmission, how many poles, easy peasy. Telephone, I've got copper plant, I've got fiber plant, is it passive, is it active, are there splitters, are there remotes? It's not a boilerplate, the burden for the companies to calculate this is extraordinary. So,
so we may need to look.
Okay.
We need to hear. Yeah, well, you represent the small.
Yep.
And other. I know there's Northfield, there's Franklin, Waitsfield is pretty big.
they are pretty big, I can't imagine trying to calculate on all their different,
Okay.
The state will calculate it.
it's not,
They haven't been paying very much.
they've been paying on book value, but
But yeah,
the company has to submit all the information to the state to
Right.
get this calculation. So the calculation part is not the difficult part, that's just a math equation.
yes,
But it's getting the information in order to make this calculation.
and this, the state has told us that they can do this. And it will free the towns from having to hire an independent appraiser or just take a number from the state. They will appraise it. I think our question is, we have 2 that have not been paying, by going from book to fair. The utilities, at least the larger ones, know that. They've chosen not to testify, but, they will have less variation in bills, that there will be one appraisal, so you deal with one appraiser who appraises everything the same way, rather than, 24 towns that hire 24 different appraisers, and you get $13.29 versus $13 versus, and just those kinds of small differences mean everything has to be calculated X number.
Well, I understand that piece of it, but I also understand if you were buying, 100 miles of fiber plant in Franklin, is it the same fair market value as 100 miles anywhere else in Vermont?
One of ways, I think I've heard they may look at this is customers. Obviously, if you can get 20 customers in 1 square mile or 50 customers in a downtown in 1 square mile, that has more value, I would think, than if you have 1 customer for 10 miles, which the rural.
It all depends on the size.
And there is a thing in here that does calculate things based on the rurality of the area it's in and stuff. But can I assume you would like to continue the way you are.
I would appreciate to continue the way that I am, and I know the other companies, having me represent them would really appreciate that it be continue at book value versus the fair market value.
That, I don't know if I can do it, but because the idea is consistency. But we will talk with you,
I appreciate that.
okay?
The second part in this bill, is the right-of-way fees. And there is an exemption for small communications carriers, which are the companies that I represent here. And we appreciate that exemption. But there's still some concerns with it. Go back to that one in a minute. The concern with the way I read it is we're exempt from the fee, but we still have to file an inventory annual. And that is quite burdensome. And I have a lot of questions about how to even calculate the inventory on, there's a fee per linear foot. And it's common practice to overlash. And so what overlash means is you have a steel messenger wire attached to the poles. And then you have a lashing machine and you can put multiple wires, fiber, copper, both, and overlash them onto that one strand. So when you look up from the street, you see one line and you think, oh, that's one line. Could be 3 or 4 lines that are all
Hanging on that.
hanging on that,
Yeah.
that overlash. And so the price is linear feet, but it makes no mention of if they're overlashed. And also it's in the state right of way, but in rural Vermont, just because we're in a state right of way, the line goes back and forth. Sometimes it's in the right of way, sometimes it's not.
right?
All the customer drops that will go across the road. You have to count those 50 feet.
I don't think it's when it crosses the road. I think it's the pole is in the right of way. And I think we've heard from the big carriers that because the right of way is X number of feet from the center line,
Right.
They're gonna have to send people out. They have a computer calculation as to where your pole is, but if that's 10 feet or 11 or 10 and a half or 11 feet from that center line, which may or may not be clear given on how, well, it's the state, not the towns.
Yeah.
But on the state highway, we understand that's gonna take some effort. And we're gonna extend the lines. After that, you should just be able to add the lines. If you put anything out to the state right of way that year, you should just add that. It shouldn't be a huge burden.
There's devil in the details, so it's still unclear on those issues. The current legislation, we are very appreciative that we are exempt from that fee. However, what happens is I serve the town of Franklin, but I pay for services to have my long distance calling and my internet service go out to the world. Those are bigger carriers that are in state right of ways that will be charged these fees that will get passed down to me, which will affect the affordability of broadband to our customers. So that part is sort of, you don't really think of it like, oh, we're exempt, but, and, like,
You don't exist in a vacuum.
right. Right, there's impact, and at first I was doing the calculation on the 2-cent rate, and then I realized I am in a county that is at the 7-cent rate. And so just a mile in the right of way is $370 increase, that's 1 mile. So, it could add up, I'm not privy to who's in what right of way and stuff, but those fees can really add up and those really can affect customers. I had one thing to go back to, I am still concerned that it's a lot of work to do the inventory, even though we're still required to. There is a good, I did have a question on, or concern. Not very good at reading how this goes, but it's section 7. C, the way I read it, if we're not allowed the alternative tax, it looks like you're taxing you would tax Franklin twice, the new tax in 2025, and continue with the old tax in 2025. So if that will just needs to be clear up on that.
I don't think we have calculated any of your old tax, because I don't, this is the first I've heard of it. I saw Representative Sims come in. Did you hear about, we've got two small telecoms that operate on more of an income tax? Would you?
Yeah, so there's currently
Franklin
an
and
alternative and that would no longer be the case looking forward.
Okay, so you did not allow them to continue as they were? Any reason?
I think again, our kind of theme throughout the bill is modernization and kind of
Did you
consistency.
get any cost estimate as to what it might cost them?
We were asked whether we could provide that, and the response from JFO was that that would be best for them to work with their accountants. And
Yes, no, JFO.
we don't provide that kind of customer specific.
So if you can. Well, you can't until you do the polls. And at $370 a mile.
That's a right of way. There's two parts of this bill. One's a right of way and one's a taxation on property
On
value.
property value.
Yeah. They're two separate
Okay,
ask from, demand on our company.
we'll see if we can tie down the numbers. I don't know if we can for you.
Yeah, that's fine. It's just the way this is written, section B says the last payment, back here. Section 7, which is telephone tax repeal transition.
Personal property tax. That you're not paying that.
Section B mentions the alternative gross receipts
Okay.
tax, and it says that will go through all of 2025, and the last payment will be January of 2026. And the next item C says that companies will need to start paying the new tax on January 1st, 2025. So it
So
means
you've got double taxation that
double taxation. I think it's just a little typo miss thing.
we can fix.
So I just want to be clear, there's two parts to this bill. One is how the property taxes are done for telephone companies, where Franklin can have the alternative. The others are doing a book value. And we'd like to keep book value, and we'd like to keep the alternative tax. And the other is on the right of way fees, which is a new fee completely, that we're exempt from. We still have to do the inventory, but we're exempt from, but it will still affect customers because everybody got calls from somebody else and that, through somebody else. So it seems like, oh, it's not a big deal. The big carriers are gonna pay for it. No, the customers are gonna pay for it.
If you've got a very small market and we're exempting municipal CUDs, right, from this bill?
Who's we?
Well, the House bill is exempting,
Madam Chair,
yes.
we have a House bill that has a theme of modernization. Aside from the problem that things haven't been modernized, what's the problem we're trying to solve? Why would we be doing or calling for mandating an inventory? If we feel that that's an important thing to do, then we might write the procedure for how the inventory would take place if we were to call for it. But unless we know what the problem is we're trying to solve, other than to modernize,
Well, I
what we're
think
trying to solve.
what I heard was that right now, we have a telephone personal property tax. It was a communications, it's been in since the 1940s. Communications has gotten much broader. There's not just electric and telephone lines hanging up there. there's fiber, there's, you know, all, yeah, all kinds of things that are out there. Wireless. And so we're trying to get all those communications under one taxing scheme. I think it's also, there was an effort to perhaps make a little money for the ed fund because more than I think we're gonna put under, more than property valuation is asked us to put under is.
Well, it's also
Those
an
are-
existing tax that we just
Those
never
are,
We collect, no, we collected it.
Oh,
Yeah, oh, yeah, no, every town, they, Montpelier, when I was there, I'm sure they still do, hire an outside appraiser to appraise the poles and lines, because,
in the right of way.
you know, like phone lines,
Right.
no matter where they're located.
Right.
The third part is that we have a law on the books that says that the Department of Transportation will collect a fee unless they think it's providing a bigger common good. It has annoyed quite a few people that they have not collected the fee, nor do we have an inventory, and I've heard quite a bit of testimony saying we should know, for whatever reason, what kind of private facilities are located on state property.
well, the witness is in a difficult position because the inventory hasn't been done. And we haven't stated any priorities on what we think will happen when it's done. And the witness is in a difficult position to sort of react to what's in place now, without knowing what we plan to do.
Right.
Am I?
Yeah.
So maybe we ought to divide this into stages, which is find out what's out there. And then present some proposals once we know what's there, so the witness knows what we're asking, demanding, or doing, and
I think
but this bill is it's exempting things based on ownership, and it's gone well beyond, monetizing. It's making policy decisions without a way to know how one would go out and tax, what the assessments are and what's the policy for assessments. So
well, we have, in the bill we've already voted out of here, turned the responsibility for appraising poles and wires to the property valuation and review, and this has been in the works for a number of years. It's supposed to save towns time, and it's supposed to, by going to fair market, that it will make towns some money. Franklin and Thompson are caught because they're exempt from the poll fees, but it's gonna take them some effort to go out and find out where their polls are. But the big change would be if we, and the bill does right now, keep that under the same, change the whole structure. They have been paying the gross receipts tax. The railroad lines, which is the other thing that goes through multiple towns, pays a railroad's gross receipts tax.
I'm sure what they pay
Right,
is based in antiquity, and if we're gonna honor what the House is doing, which is trying to come up with a system that's based on some modernization, we can't do that until we have the appraisals, and the appraisals follow the recommendations or rules that we've set out. Such as, will it be on the cost of the materials, will it be on fair market value, will it be on whatever
we
we
had,
recommend?
Senator, your request for this, we had property valuation and review in yesterday,
Yes.
and you didn't say you didn't get your answer. So do you want me to have them back? We
No.
can't,
Madam Chair, if we are going to have property valuation review,
yes,
assess these properties, we have to tell them what we want as a result. Do we want to have fair market value? Do we want to have the cost of construction? Do we want to have the value of the nuts and bolts and wire? And we haven't done it yet.
It says there.
It's in this bill, it says.
They come up with a model.
But the bill
For
also
valuing
exempts some companies from the appraisal.
For the right of way.
Not
For
for
the
the,
property tax,
the,
unless it's a municipality.
which is the CUDs.
Correct.
And I'm, at some point. I mean, we have municipal telephone companies, are they, if they're not, Northfield has a telephone company.
Is it a municipal
That's TDS.
corporation?
It's a corporation.
So to Senator McDonald's point, the exemptions are only on right of ways. There's no exemptions that we're talking about. Telephone tax.
Property tax, not unless it's a municipality.
It is all the CUDs.
All CUDs are municipal.
Plus, we're exempting Comcast because it is
That's just for the right of way.
just as the right of way. Okay. Right now, we tax the poles and wires. And I guess we tax it on book value. Every town either takes what property valuation gives them or it hires its own appraiser and appraises them. That gets costly. They're saying they are going to do it based on fair market. We've been told it will raise more money for the towns and for the ed fund doing it that way because it is a real estate. We haven't had any issue with that until we've gotten to the small folks, two of them, who for generations have paid based on a different method. We can choose to just exempt them. If they serve less than 1,000 customers or something.
I just want to explore continuing the exemption. It strikes me, tell me if I'm wrong, the exemption is not arbitrary, it's historical.
It's historical and there is, so when you file it quarterly, based on where your revenue is, there's a percentage table tax department has. So, I think the top tier is 5 and 40%.
And with any exemption, with any proposed exemption, the question is why you? What's so special about you? I start saying it probably is something special, you're unusual. Okay, well.
They're very special.
How unusual your operation?
We're pretty unique.
When did you start?
So we started in 1894.
Okay, there you go, because that was before telephone, so before there was a poll tax. And this is the way we tax railroads. There's towns appraise the railroad lines. Well, I've never heard of Waterbury getting a property tax off the railroad line that goes through town. There is a railroad growth receipts tax, has been probably since the 1800s. So
these are telegraph lines that were taxed?
no, she's got televisions.
Before you had.
It was before me, but
Yeah.
yeah, but in the late 1890s, it would have been a telegraph.
Oh,
Yeah.
They quickly turned into a telephone. line.
It's historical appendage.
And we're looking for uniformity and consistency. That's inherently at odds.
Right.
And that is historical survivors of the things that are
Well,
left.
I think what makes me uncomfortable is I can't say what your pole and wire value is going to be, so we can do an apples to apples. Is this might reduce your costs? I don't know. Is it going to, how much of a financial impact is it gonna have on you?
I don't know.
And neither do we.
And it's not just me, it's my customers.
Yeah.
And it affects our library deployment and it affects our customers' rates. That's the bottom line.
So you want to transition,
I
Gary?
wanna know what's out there. and then allow a committee like this and the people that are on it to make recommendations on how you might tax it if you were gonna,
How would we have to eat, we are taxing.
how you might tax it in a
The-
modernized fashion.
Okay, well, we'll have property valuation because they have come in and brought the proposal to us to tax it in a modern fashion. And this time, ask them the question.
So I would like to know what the cost of the materials, what the cost of the installed thing is, and what the fair market value is. So the next finance committee, with the help of other committees, can answer those questions.
Okay, we will get property valuation back in. Maybe we can talk to their appraiser.
I think we're gonna have to,
What,
if we could talk to the actual appraiser.
it depends on probably if he's under full contract or if they're gonna pay him a couple $1,000 to sit here. We will ask, because I think he's maybe more technical. But we also have a decision to make about the two small that have been paying based on a different schedule.
So we may learn it's comparable. You're concerned about the unknown.
Yes.
This could, you don't even know how to value some of these things yet. And this could be a very different cost burden and it's
And we
very
get
be
passed on
concerned
to
about
the
the unknown.
customers. And we haven't dealt with the cost issue yet for internet broadband. It was the one thing we didn't get to, because there's no easy answer. But I think that's, again, the balance.
No, I'm new around here, but I do remember in the streaming tax bill, we did have an exemption for any company that had less than $250,000 in revenue. So I think there's some precedent for carving out a small guy. May I ask, is this public knowledge what your annual revenues are?
No.
Okay.
So we can, yeah, and this bill does carve out small carriers for the inventory and, the auditor said he hopes we didn't do that because some of them are big carriers nationally, but, we can go through this and we can decide if we want to do trade-offs. And then we'll see if we can get some kind of an estimate to know what's gonna happen to these small, well, we've got two.
Well, even for the other companies, it's still an unknown when you go from book to fair market. What that's valued at.
Yeah.
And what I've learned being in the fiber and the internet business is, equipment doesn't have the life of legacy stuff. You know, when you buy new equipment, you know, it's like you buy a computer. Yeah, brand new computer, and like 2 years later, you're like, oh, this thing's trash. I need, you know, it's the same thing with, I just have massive rooms of this equipment.
Yeah.
So, you know, the added burden of cost of that, and then with the taxes, I assume they're not going down.
The estimate is they'll go up. That's the projection.
Yeah.
Because we are going to fair market. Well, yeah, Rebecca gets one of your poles that appreciates real fast. And that's been an issue. So, we'll try and get you some answers.
So I appreciate that. Thank you for your time and yeah, just trying to get fiber out there and keep rates affordable and changes.
I think that's, yeah. Pretty much, I don't think you wanna price people out of these internet markets.
Okay, everybody look down, there should be like, oh,
Ooh, that's a good bread. No, thank you. Oh, thank you all the way down. You can zoom.
I can zoom, but it's always easier to be and to understand who you're really meeting with.
So I appreciate that. I feel that too. Okay, thank you. Okay, next we have Stephen Whitaker.
Not the ability to go out for your amendment for all first. I'm gonna
We don't have any amendments at this point.
think you're not putting this on.
Under Renner,
Okay, Senator Renner.
Very good. Do we have the amendment or is it?
on the committee page, I just received.
If it's short, I don't need it. It's not short.
See,
Okay.
thank you.
Got some.
18 papers.
Okay.
Not quite sure.
It's 18 pages. Okay, Irene, if you've got 18 pages, you represent.
But I have fewer than that to speak from summary.
Here's the leader side.
I did, okay, first time this week. All right.
Let's start passing these around. Well, let me take.
Okay. Okay.
There's the first batch.
Okay, the floor is yours.
Thanks, Chair Cummings, for the invitation to speak today. My name is Irene Renner. For the record, I am a senator for Chittenden North. Having worked for 10 years with Hardline Software in both mainframe and microcomputer environments, I was pleased to be appointed to the Joint Information Technology Oversight Committee last year. One of the things I've asked JITOC to deal with is the double poll problem. Not only are double polls unsightly, they also prove to be a safety hazard for your average Wichita lineman. Double polls have been a long-time issue that should have been remedied after the sale of Verizon to Fairpoint, at which time $1 million were reserved to assure the removal of double polls. They still exist all over the state. Have you noticed them down along Port Street? I see them every day as I approach the State House. This amendment would, among other things, add a GIS to an inventory of utility and communications property. Once the state has all of that information, which was an effort begun in the 1990s, we can net some additional income. We can also start to resolve issues like the double polls and the poll hygiene, which is the clutter we see currently on a lot of polls, double or not. Over the years, I've closely observed regional dispatch development, both at the county and state levels. I'm aware of the need to get those initiatives off to a good start. While the Public Safety Communications Task Force develops a regional dispatch plan, the Finance Committee must begin to determine how to fund that effort sustainably. It's clear that we've hit the limits of the personal property tax as a funding source. What could possibly be a lower hanging fruit than charging private utilities and municipal corporations to rent space on our public rights of way, a revenue source that's already in statute, but uncollected? It is, for all intents and purposes, veto proof. My grown daughter is trained in GIS. She spends her days mapping land use in a geographic information system. That is, a map with attribute tables where data lives. Every bit of data in these tables is linked to points, lines, or polygons. What a GIS enables is analysis both of table values and spatial relationships. One could use GIS info to determine where are the most dangerous intersections and at what time of day. Or what is the fastest route for an ambulance? As we map via GIS our right-of-way infrastructure, we will also be preparing ourselves to respond more effectively to disasters ahead. These amendments simplify the House bill by taking the price list out for now and getting a uniform database match. Thus teaming up for next year's legislature, the ability to make well-reasoned surgical decisions about how much rent to charge for whatever it is that resides in the public right of way, and how to do so in the most equitable manner. Along the way, we would also be creating new revenue options for towns that choose to monetize their own rights of way. Our GIS will enable them to see where the pole squatters are hanging out. Unlike the state's federal aid highways, the local right-of-way rent would not need to be deposited into the transportation fund. But it could be used to shore up the local public works departments, for example. No more potholes, or at least a lot fewer. Currently, the state has set aside $11 million for regional dispatch, but there's no plan yet for how to spend it. About $1 million of that amount is spoken for already. One of the charges for the Public Safety Communications Task Force is to determine how to sustainably fund their effort. In these amendments, we complement that task force effort by setting up a process for gathering the necessary data to analyze funding options for regional dispatch.
Okay, this bill is not about regional dispatch.
Yeah.
So
It's a way to fund it.
depends on how much you set that poll tax in.
There you go.
This amendment proposes leveraging some of that task force's unobligated general fund money to develop a much more lucrative revenue stream, both for regional dispatch and for towns. Not to mention the state's public benefit, such as 988, PEG, self-coverage, and so forth. This inventory building can be concurrent to the regional dispatch planning. Ideally, the dispatch plan will arrive at the station just as we begin charging right-of-way rent next year based on this GIS model. Here's a quick summary of what's in front of you. The first instance of the amendment removes from the Universal Service Fund the 17% earmark for the broadband board and ensures that 911's needs are met by the Universal Service Charge in Section 3. Broadband board has plenty of other sources of funding for the foreseeable future. The second instance of amendment puts the broadband board at the bottom of the waterfall from the Universal Service Charge after 911, so there still will be some funding for the new 72-cent line fee. The third instance of the amendment relates to the communications property tax, formerly the telephone personal property tax we discussed earlier. The Division of Property Valuation Review would cooperate with the agency to use GIS as the base for this inventory to help it find out what is where at last. The fourth instance of amendment appropriates new money in the Public Safety Communications Task Force funds and still includes $150,000 from pilot special funds for use by PPR. The fifth instance of amendment lays out the highway and right-of-way inventory process and economic modeling. Again, the what and where behind the amendment. This removes the nearly unlimited discretion in rent exceptions by the Secretary of Transportation under current section 26A of Title T. Rulemaking instead is required by the amendment to make it transparent, consistent, and fair in rent setting. And of course, this can be tweaked in the future. This section also requires the Secretary of Transportation to contract for a study with an engineer and an attorney to assure two things. One, that the information that is already public and visible stays that way. And two, to assure that trade secrets, critical infrastructure, and system security would remain confidential. Finally, the study also addresses CUD confidentiality and transparency needs. It requires the agency to create a portal for which renters of the public right away can enter their own data as things change. And then they can begin paying sooner rather than later that rent. What I learned on Tuesday in this room was that we had neglected to collect the public property tax for 17 years. It's time we figure out which utilities are free riding on our rights of way, and have them pay their fair share.
Are they free riding? Because the telephone lines go through my backyard. They have right, I don't get paid to have them go through my backyard.
You have an easement, right?
I never signed it. They were there when I moved in. I mean, the easement was granted to them. But we granted them the permission to be in the public right. I'm not sure And I'm sure if he asked, why shouldn't they pay to go through my yard?
Great question. I was told that we're doing right away, right away here.
Well, that,
And
an
you
easement
certainly
is a
modifies
right,
your-
I mean, an easement is a right of way, it's a right to go through my property.
Well, that should be mapped at least if it's not already.
No, we actually have some that have never been mapped or not even known that have been there since the thirties when we did the electrification. We're just finding that out, but we know that we found ones that we don't have easements for. They're just there.
That would certainly be an appropriate thing for us to request that inventory was being done. For those of us that have electric lines on our property. About. Yeah, but, yeah. How the rights of way work.
Well, I'm. Go ahead.
One caution that was raised a couple of times, and I'm not sure if the language fully addresses it, is that the monies collected for any right of way charges, according to federal law, has to be dedicated only to the maintenance of that transportation corridor. And it can't be redirected to other funds. It's sort of what we have butted up against. But I heard you mention that this might be a revenue stream for regional dispatch and other items. Do you walk that line where the revenues collected from right of ways will be confined to transportation fund activities only?
If they're not along federal highway or something funded by the feds, right? If it's along just a local road.
But
So the feds don't have any.
I had a similar question. I issue easement on land that I own. It's a one-time thing, and then they have it in perpetuity, and they can't charge leasing. I guess where this comes in is there's maintenance involved, like cutting branches down or weed whacking around poles. Who's gonna pay for that? But that's
They
what.
come in and cut a lot of trees in my backyard without asking. They just come down. So be interested in equity. I don't think we're gonna make enough money to do anything huge. Okay. We're going back. Thank you.
Thank you.
Question. We're going back to healthcare. Life is always interesting in this room. Today, we're going back to 766, and Kelly Lang, is Kelly? I'm here. You're here. Come on up. Thank you.
Did you forget me? Sure.
What?
Did you forget my?
I thought you said you weren't ready.
No, I just said I wanted to go after the amendment.
Oh, I thought you said after our event. Everyone making it, so different hour. I hear, different hour. Okay. Come on up. No worries.
Thank you. For the record, Stephen Whitaker. I have been speaking to this committee over the last 3 or 4 years about the right of way and the health and personal property thing. And I'm glad that it finally rose to the level of bill to be discussed. The amendment that has just been presented to you, I provided some input on to Senator McDowell and Senator Brenner. And I believe that it addresses most of the concerns I've heard, that it's premature to impose new taxes or repeal alternative minimum taxes, such as Ms. Gates referred to, prior to even knowing what the contents of the public right of way is and what the values of the property that to be taxed are. So a data collection stage for a year would inform and provide a valuable tool, a dynamic tool where you could play with different rates for electric or for fiber or for cable or for different infrastructure. That cabinet hanging on the second pole down Court Street belongs to Consolidated, and it not only hangs in the public right of way, it blocks the right of way that this sidewalk snowplow has to hit. They should pay an extra premium for that. You'll see it on the second pole down Court Street. The inventory.ngis was proposed back in the 90s. That grew out of the Office of Policy Research and Coordination as Act 200. The planning law was promulgated. GIS was a part of that. We spent hundreds of thousands of dollars on a firm from Frankfort, Kentucky called Pine Graphics. They proposed getting this GIS put together back then. We completed the roads. We completed town boundaries, we completed a lot of it, we never got to our infrastructure. The infrastructure is an essential piece of planning for public safety. When this gets completed, certain parts again will be confidential, but emergency management would have the ability to know that if a certain pole is taken out and a fiber is cut, then this sector of people in this geographic area not only don't have cell coverage, but they don't have landlines either, meaning no ability to call for help. That kind of information is essential, especially as we enter the most active hurricane season predicted in quite some time. So I encourage you to move forward with amendment to collect the data of what it is that's residing in the public right of way. I want to point you to a section, there are current problems, there's an active effort to revise the telecom plan this year. And the telecom plan should have addressed this, and I asked to speak last year about the deficiency of the telecom plan, it's happening again. 202C prefers the statutory policy and goals of section 202C of Title 30. Prefer the sharing of infrastructure of structures as opposed to building taller structures. What we have in many areas of Vermont, and you can just drive down the Barry Montpelier Road, you'll see 4 and 5 different fiber carriers, which necessitates making space for them, necessitates removing the existing poles and putting in taller poles, rather than sharing the infrastructure. The capacity of one fiber sheet is more than enough to carry all the traffic that's moving through here. There are complications with sharing open access fiber agreements, but they merit consideration. Open access is also a goal in section 202C of statute. So I think one thing I'd ask you to consider there, you've heard problems of collecting this data. You've heard Consolidated say, we're not sure we have the data in a format that you can use or that is spatially accurate for where it resides. I've heard of another state doing the same thing who created an incentive for production of the data. Recall I said that these carriers are going to need their own GIS to manage their own plan. They have automated systems that send triggers and call people when an outage happens. The carriers need the same data in a geographic information system. So we can either build it for them and charge them a higher rate for use of the right of way, or we can give them an incentive to get their data in order and get it to us as part of this inventory. So that's an important piece that could actually make it possible to get this job done in a year or a year and a half. With regard to Senator Chitten's comment about the federal share, the 80-20, the 90-10 rates, I believe there's still an open question of whether or not the revenue from the right of way has to go into the transportation fund in that same share or all of it. But I've also spoken to the Secretary of Transportation. Highway safety necessitates cell coverage for the ability to call for help. So even if most of this revenue from state aid or federal aid highways had to go into the transportation fund, money for cell coverage infill to complete our cell canopy could be pulled from the transportation fund in that same nexus of highway safety. And a similar argument could be made for the ability to dispatch help along the highways and regional dispatch. But I believe there's a nice synergy here between the effort going on for the regional dispatch radio plan and both the sustainable funding source as well as the information necessary to know where we have coverage. There is a group called Mission Critical Partners, national firm of 200 experts that's been retained for close to $1 million over the next year to put that plan together. This inventory effort, should it go forward, would complement that nicely and move them both forward so that next year's legislature, I would suggest this GIS tool could be made available to joint fiscal to model how many, I think in real estate, it's called the mill rate. But you could charge a certain number of pennies per foot or per fiber strand or per cabinet or whatever, and model it different ways and decide who you want to consider exempting based on size or historical precedent or whatever. But this is the best practice today in utility management and in tax, is to build it into a database that allows this flexibility. And the study on confidentiality, what should be public, would serve everyone well, because the CUDs have been operating in an entirely secret mode, using tens of millions of public money, and that's not sustainable either from a public trust and accountability point of view. That's most of what we have to answer. Any questions?
If not, we'll get into where we are on this bill at some point. It needs to get out of here or not, but we want to make a decision.
All right, thank you.
Okay, thank you. Now we are going to go back, and we've got Kelly Lang. Kelly, welcome. Stand up. Introduce yourself for the record, Viola, and the floor is yours.
Oh, go ahead.
Oh, okay.
Good afternoon, everyone. Changed name, Kelly Champney, so if you see confusion, my name has changed, so it's still the same person, just letting you know.
Did you get that changed in the record?
It's changed in the testimony, so you'll see that, just don't want to confuse anyone, so. Thank you for having me today, just a little bit of an introduction and, my background. So I'm Vice President of Contracting at the Vermont Health Network, so my team, which is a small team, oversees payer contracting for all payers, including working with our state Medicaid, and in New York, that manage Medicaid, Medicare Advantage, commercial, and working with our ACOs, so traditional Medicare work. So really the full gamut of what I call payer revenue is worked through in our team in terms of contracting. I also matrix with the oversee teams in terms of billing and claims edits, and working in collaboration with our medical group and the hospitals. So it's really the wider range.
Can we just get some context?
Yes.
How many people and how much that costs for a medical network?
Certainly. So the contracting team, I'll say, is small, it's 11, but that's just the contracting. Across our system, there's approximately 200 and over 150, I think was the last number in Vermont. When I say system, we are trying to streamline to save costs across administrative. So that is in terms of billing people, so people working on prior auths, claims, the admin revenue side. What that number doesn't take into account is the doctors and nurses, the physician's assistants that are involved in the time, or administrative leaders. So it's really a wide array, but there's quite a large number of staff involved there. So moving forward, and you have my testimony that has my full background if anyone has questions, but I just wanted to level set, because I know you had several testimonies about this bill, and want to level set and kind of why we're here, and what kind of the overall large that our collective and our providers has really looked at. So first, you've heard impact of the administrative burdens that are addressed in this bill for providers across the state and across sizes. So not just the health network, not just our small hospital and large hospital, but physician practices, FQHCs, independents. So this issue is not silent. This issue is also across payers. It's not just targeting one payer or the other. And what we're really focusing on is alignment, transparency. And I was joking in Senate Health and Welfare, I overuse the word alignment, but that is really the focus of where we're trying to get progress. This bill does not get rid of any of the safeguards that have been discussed, step therapy, claims edits, or prior auths. It's not a blanket waiver, and that's not the ask. It's how do we make the process and expectations more uniform, so we, as the healthcare provider system, know what to do when we're submitting a claim, when we're submitting a prior auth, and the rules of the game don't change. And you've heard testimony that there was a claim to edit standards with Paul Harrington. I was on the same group with Mr. Garland. And yes, this issue has been around. So why are we bringing it up? Why is it such an issue? I made the analogy some time ago is we all get paper cuts, and there's a lot of little paper cuts, or in business, there's a lot of cuts to revenue. And eventually it gets so bad, I use the cardboard cut. When revenue's gotten cut by cardboard, it really hurts your finger, and it's way worse than a paper cut. What's happened through the use of technology, increased AI algorithms, and how payers have implemented some of these edits, it's got to the point where the little cuts have added up. And that's where new technologies brought us from the Paul Harrington claims edit days to where we are today. So not to say that there wasn't good work back then, but just like everything, it was different. There wasn't the same use of the policies that we have today. So I think that level sets the history of why we're here. And with that, what we're really talking is burden that gets to not only claims processes, but communication, staff. You've heard about burnout and, you know, all those topics you've heard before, but really impacting patient care. Because ultimately this takes staff, especially the nursing and PA staff, that cannot provide patient care because they're on the phone or working with providers, and again, across providers. So we've tried to address this through payer meetings, DFR, we've had that, and that's really where we got to the legislation, because what we're not seeing is traction from our payers of how to know what's expected. And I'll give a concrete example of last week. We went, this gets to the claims edit issue, and I'll go through the standards of what we're looking in each bill and what it does, or part, and what it does or doesn't. So claims edits. We've heard what claims edits, you've heard the testimony. The thing is, we want to know how we should bill correctly that's going to result in accurate payment. When we've asked a payer or tell us the list of claims edits we have against us, so we know, because each payer does things differently and uses claims edits differently. We were told last week, we don't have that list, we can't give it to you. So how are we to know? And this is not just we, the health network, this is we as providers and clinic staff, to submit, we're billing accurately, but one payer is using a claim edit and one payer isn't. We're not sure because it's different standards, and it shouldn't be a gaming of how to bill each. It's again, understanding the rules. If you take it out of healthcare and you're to pay an electric bill or some other bill, you know what you're getting charged or how you're supposed to pay it, or you know what the standards are for you to get revenue as a company. And that's what we don't have, which therefore takes burden. And despite testimony in terms of claims edit, that it doesn't delay, the claims edits by Blue Cross, we've heard from providers, delays care, prevents care at times when patients are asked to come back. And we have claim edit denials that are well over 60 days that we're not getting responses to. So those are the reasons why we're here. And we're not saying don't go with claims edits. So I'll go to what the claim edit testimony, or excuse me, section focuses on. It's alignment with NCCI, which I think you've heard again what claim edits are, but that is not just Medicare. NCCI is an organization nationally that is the National Correct Claims Coding. So again, correct, we want to code correctly. Medicare and Medicaid uses them. There's also a standard for what Medicare uses for inpatient. That's covered within this bill. Medicare and Medicaid covers the entire demographic and age from newborn to elderly that it would be included in the claims edit. So these standards, which are national, which are used by two largest payers of any panel within the state practice, are standard, and how their process is very similar. Payers use a version of those, and then specialty and other, when I say payers, commercial, excuse me. Commercial payers use those standards as well, but how they apply them, when they apply them, is taking a rule and then deciding, we want to apply it, but we're choosing, and an example is, you have to have a certain diagnosis code. And one payer will say, well, not only a diagnosis code, but a prior visit. So there's different standards on how that same edit is applied. So what we're looking again is not to say get rid of the edits. Say some providers would just say like to get rid of that or prior auths. We're not getting rid of it. There's appropriate coding. We're asking for transparency to know when these edits are applied. So we ask a list of edits. What does that mean? To be able to get a list. And then we're asking to then again allow for audits. If we're not billing appropriately, we want to know. We have a very strict compliance office. In our facilities, we want to make sure we're billing. So this again is not removing the claims edit function, but that's why we're here and what we're looking to do. The prior auth is a very similar conversation. And again, you heard the clinical reasoning of what prior auth confusion is using. I got another email today from our facility pharmacy team of how prior auths are increasing burden to them, therefore decreasing access because we cannot get prior auths. What this legislation does is, again, allowing for alignment, allowing for exception if appropriate. So for example, we're aligning with Medicaid. If there is not a benefit covered by Medicaid, payers can have their own standards. We're pretty fortunate in the state in terms of Medicaid covers a lot of what commercials, at times more. And so that does capture a lot of what the payers do. And Medicaid has reduced PAs in certain areas like radiology and lab. And what has been discussed is the cost shift. This legislation does not address the cost shift.
Yeah.
It's not supposed to.
And there's an essential difference between an insurance company, if Medicaid runs out of money. The federal and the state government put more in. So there is an essential just financial basis as to what one is a state benefit program. And the other is a choice. And so we're trying to, heard a lot of providers tell us this is an annoyance, it's burning out their staff. But if we take, if we go through with this, are you going to be able to cut your costs to offset any, feared increased costs? Because if people, and you're really hitting Blue Cross and MVP, because those are your two basic insurance companies, all the rest that are in ERISA programs. So anyone that's working for a self-insured employer is not covered. So you're still gonna have to go through this, perhaps with the same companies that are, managing the self-insured employers program. So how much of a difference, what percentage of your pre-auths are in that basic on the exchange private purchase
So we
healthcare?
put a caveat on one thing, a lot of the self-insured to date follow the commercial. And so again, it's not set, we don't know a self-insured group from Blue Cross or not, that's not how Blue Cross reports it to us. I will say they follow much of the same terms. So where this may focus on the commercial, which I would also include Cigna, is enough of a population that would make a difference. So if we're including Medicare
Cigna has testified, all three have testified, they have concerns about having to use different standards in Vermont, especially MVP, whose bulk of business is in New York State, they're a New York nonprofit. About having to use different standards. And we don't have many insurance companies writing in this state. And I don't want to, lose another.
There's a couple of questions I'll go through. First, the percentage, I don't want to miss things that you've asked. And so the percentage of our population on an estimate, I'll say first, I'm lumping in Medicare because we know Medicare. Like we know the rules. And again, the purpose of this legislation is knowledge.
But
So Medicare,
not being impacted, so.
Medicare, Medicaid, and the commercials together, if you put that, would be approximately the high 60% of our business.
Just the commercial.
Just the commercial, for that.
That's who we're going to be impacting.
And I will get the exact numbers, because if we're putting 20% on top of the Medicaid, would be the fully insured, but again, I will lump in the self-insured on top of that. We're getting a large portion. So again, I'm trying to bulk in Medicaid and commercial as a percentage of our patients seen.
Okay, but this would only affect the commercial insurance. It's not gonna affect Medicare and it's not gonna affect Medicaid. It will all, and you say it's going to relieve you of all this pre-auth burden. What I'm asking is, what percentage of your patient base is that commercial? If you're only gonna get relieved of 10% of the pre-auth, and all the ERISA folks out there are still going through that. I'm just trying to get a sense of proportionately how much time and aggravation you're gonna save in proportion to everybody else.
So I'm pulling up one number just to see what I'm trying to do. I do want to say I'm bringing in Medicaid because we're aligning with Medicaid. So it's important to know this is the bulk, and that's if you align with that whole number.
But you're already doing Medicaid. So I'm looking up for just the commercial insurance companies that are writing book in this state.
So
They're basically on the exchange.
Yep.
Um,
So the bulk of it, this is 2022 data estatements, just letting you know, so if you give me a moment. So if we are doing. Trying to click numbers here. Missing MVP for some reason here. 30-ish% of our patient visits. And so just again, our data
I think that's just what I'm.
is approximate.
Yeah.
When I'm pulling in what are the commercially insured, some of that would very transparently include self-insured because they don't differentiate right now.
Right.
So just not even estimate based on older data and quick review of the payers. Probably 30, and I put that with then if you put our Medicaid population, I know I hit on this and I understand what you're saying. You put that together, that's 50% of our population that would cover the same standards. So providers could automate or know.
Okay, but you said you put the self-insured in there.
I don't have a way, Blue Cross
Yeah,
doesn't designate, so
that's because the self-insured are not going to have to abide by these changes, and I think that's just trying to figure out. It's a great burden, but if only leaving 10% of it, is it worth the risk to increase rates?
one question I would just ask or statement, I would say. When we get to the prior authorization focus. The same question could be the value to the payers, if we're getting at times 90% approved.
Right.
What's the value to the payer for even doing that if we're in the high 80s and 90s? So a question back of that process. Completely understand.
Do you get food?
There was, the certain numbers, it depends on area, but yes, I would say on average, and especially this claims edit, which I know is not prior auth, but similar. We're getting back approximately the 80% approved, and that's still with claims not properly processed to date, so. Certain areas are lower, and again, we, just for context, if we go a global budget. We need to be responsible as a hospital, so prior auths and ensuring appropriate use of care. Again, it's not why we're trying to get rid of them, we're cognizant of the cost as well. And so it's important, so we wanna look at outliers, and that's what the system does need to, and to get to your point of. Our question in terms of what will this do to reduce costs as part of the accountability study, I think in section 7 of the bill, that payers and we, the providers, have to say how this has impacted. Us, and I think we need to seriously look at that and how we're being held accountable.
So you just started talking about prior authorizations, and maybe this is more of that than it is on the claims edits, but the dragged out issues that you have with doing the prior authorizations, are they most often are you getting with Medicaid, with Medicare Advantage plans, or are they the commercial health plans that cause you the most grief with the lengthy processes?
We didn't talk about Medicare Advantage here.
We can talk.
We talked about it. But
We have, so from the anecdotes, but also we're starting to pull data. I will say no system has perfect data on this yet. It is across the board. So starting actually in order, Medicaid, we have some issues with, but the billing team has very easy in terms of how to work with. Medicare is known, so that's again, we know the standard. MA, clear problem you hear nationally. What I think is federally, they're getting attention, much like this bill. There's changes that we're very excited about. Again, the changes are standardization and transparency and review time. So Medicare Advantage is going similar to where this bill is and uniformity. The commercials, it's across the board, especially when I am looking at, in hospital-based, pharmacy utilization. Gets a lot of delays there, and I know you've had testimony about that. But even, getting MRIs and the 24-hour, 48-hour, testimony, I believe was here. We've been in a couple of committees. Getting that turnaround is very much a commercial payer issue as well. And the comment of, well, then go to the emergency room, because if you can't wait 48 hours, we want you in the emergency room. We're trying to reduce costs. If a provider says you need a cath lab, honestly, an issue I dealt with earlier today, and we don't want you in the emergency room because you don't need to go there, you can go right to the cath lab. We need now 48 hours where we could get that person in, avoid the emergency room. So that 24 hours is real. We don't want people showing up in the emergency room if we could get them into radiology quicker without a stop in the ED. So that is very much a commercial issue. That was the issue literally today. So just giving you an example, it is definitely not just a Medicare has to deal with it. It's what we can do in the state.
Quick follow-up. So is it mostly the commercials that are causing you the most grief, or is it more the Medicare Advantage plans?
I would say both. It's hard for me to, I will say it depends on the area. If we were talking throughput, getting people out of the hospital, I will say MA plans are the worst. But so prior auth, I hear it more with the commercials. It's probably 50-50, really, I will say. Yeah.
They're also the ones that are into saving money.
The Medicare Advantage plans.
Well, also commercials. We have charged commercial plans with keeping down the cost of health insurance so people can afford it. This is one of the techniques they've been using. We can.
We're just, I would say again, to the cost, I think someone testified, we're not, I think, or Representative Black, we're not sure of the cost avoided, that, you know, if someone, again, we want, using the cath lab example, we would actually be saving the system money, because I will say some systems will tell that person, go to the ER, just check in, and then we'll get you, so now there's an ER bill and a cath lab, so we don't have the cost avoided.
We won't know until it rolls out. The risk we're taking is that when it rolls out, we will find a number of people or a number of small businesses who cease to carry or provide health care. And, you know, we're trying to do a cost benefit here and figuring out where to go.
Well, I mean, we are tracking ER costs year over year, right? Because we know they're escalating.
We track usage, so I've got to find out who does that. And if we can find out if the usage is going up. That's the claim, but I'd like to see numbers. So,
I mean, but we know that it's an escalating cost.
if you go to the emergency room, it is an escalating cost.
And it's a major contributor to the cost of healthcare.
Emergency rooms, well, hospital costs in general and pharmaceuticals are the two drivers. So, Senator.
Is it true, that when some people say that the people who work for the insurance companies that answer the phone, get bonuses based on how successful they are in denying and stuff?
I have not heard that rumor, and we will let the insurance companies answer it and we're finished with this. I think that might. Did you hear that on the internet?
Pardon?
Did you hear that on the internet? I haven't.
No.
I have not ever.
I've heard it in this building.
Oh.
Not on here.
It's as bad as the internet. Okay, we'll get back and get serious. It's been a long day.
Respectfully, I can relate on that. My testimony I did file, which has clearly more information. I just wanted to highlight the importance of this as an important step in the state ensuring, again, not just simply the access to care and understanding the cost focus, clearly that's a focus here, but also to the workforce issues and where we can't hire nurses and providers because some of them are doing this stuff, not for us for payers. This is a comprehensive first step. It does not go nearly as far as some would want, but it's a step that we can make, much like we made that step with Paul Harrington many years ago. We made a step.
Right.
Now we need to take it again. So,
Okay,
thank you.
okay, thank you. Any other questions? Okay. And next, we have Alex McCracken. The new gold standard.
Good afternoon, everyone.
Yeah.
Thank you so much for having me today. It's the end of a long Thursday, so I'm sure you'll be grateful to know I am going to be brief today.
Yeah, we have ways to go. I think the question came up that you put off all your prior approvals during COVID. And we're interested in if you did that and what kind of results you got financially. And we also have heard that you pay significantly less per procedure than the insurance companies.
Yeah, I'm happy to speak a little bit to that, Madam Chair. For the record, Alex McCracken, Department of Vermont Health Access, or DVA. And just to say at the start here, DVA's not able to offer a position on this bill. It doesn't impact Vermont Medicaid, as you noted, Madam Chair. So we appreciate that the bill has referenced Vermont Medicaid as a model for PA requirements or prior authorization requirements. It does feel relevant to note that Vermont Medicaid does operate under significantly different circumstances, as you've also noted. And that given that what works for us may not work for other parties, we don't know what the results of that would be. To speak to the prior authorization that work that DVA has done, I'm going to pull a little bit from some testimony that we gave to House Healthcare when these bill first came into their discussion. We did, as you said, we re-examined some of the prior authorization rules around the pandemic, specifically in January of 2021. In response to legislation, a multi-unit work group was established to assess prior authorization requirements. I'm sorry, I'm looking at my notes here. I have the wrong testimony. I have it up here. As a result of legislation, the DVA team worked on a project with an objective to quote, take a methodical approach to reviewing the codes that require prior authorization in order to be able to make data-driven recommendations on where prior authorization is necessary and where we can remove the prior authorization requirement in compliance with Bill H960 and alignment with our work with the ACO. That was the original objective for the work plan that was developed at the onset of the project. There were two deliverables that were identified to create a dynamic list of codes requiring prior authorization and a documented process for reviewing the list. And to provide findings and recommendations to a group of interested parties identified in legislation regarding clinical prior authorization requirements in the Vermont Medicaid program. This team was originally comprised of members from DVA senior leadership, clinical payment reform and data teams. Other teams or other units were consulted as needed, and eventually it became obvious that we needed input from the special investigations unit within DVA, so they joined the team. We had a frequent meeting set up. We outlined a work plan with 8 original areas to review. The outcome of the original review was waiving prior authorization requirements for several services, including high-tech imaging, aligning the number of PT, physical therapy, occupational therapy, speech therapy services for other insurers, which was 30 visits without a prior authorization. That reinstated prior authorization for requirements for ACO attributed members for therapies when it wasn't required, but it raised the minimum number of visits without prior authorization for members that were not attributed to the ACO. I can speak briefly to the outcome that we saw, and I'm happy to provide more data, but we did not see a significant increase in utilization, generally speaking. We did not see significant increase in cost. But again, I would say that we operate under very different circumstances than the commercial market. And I'm happy to try to speak more specifically to some points if there are questions from the committee.
Okay, committee. Questions? Okay, so you did do the study, what did you remove? What services did you decide physical therapy be? You extended that to 30?
We did work around physical therapy, occupational therapy, and speech therapy, and high-tech imaging, as I said. We had a couple, sorry, I'm trying to parse out this.
But if you're only paying $800 for high-tech imaging and paying $8,500, you said you are in a different.
Right, it's just a bit, we operate under, the work that was done within DIVA does not necessarily translate outside of that environment. So we looked at this from our perspective, from Vermont Medicaid's perspective, and we found that this was an appropriate response from the department to look at these requirements in these cases.
But utilization would still be covered.
I would think utilization, and the emergency board gets that utilization per member per month report annually or twice a year. I think it's annual.
Reporting is annual.
Yeah, and so it is monitored.
So you had similar utilization, even though your costs are different.
That's what we've seen for Vermont Medicaid, is we've seen similar utilization. We are continuing to monitor that. That's an ongoing project. So, and this is only this is pretty new, all things considered. So we're still monitoring that data to ensure that that doesn't increase utilization.
Okay. Yeah, it is. How long has it been in place?
This work has been going on since 2023.
Since when?
2021.
Okay, any questions? Thank you. Coming over.
Thank you very much. And I would like to note as well, because I think it is worth saying, that in terms of other parties basing policy off of DIVA and Vermont Medicaid, we don't have that streamlined set of communication practices in place to relay those changes in real time. So that would present an administrative burden for DIVA and other parties. As you noted, annual reporting is what we do now.
Yes.
So that is, we would require more constant real-time updating for folks if they were going to base their policy off of us.
Okay, we haven't even gotten to a report. We don't have the bill. I think the question is, we're looking at it in the perspective of regulate health insurance and potential, if any, impacts on the cost of insurance. So that's committee. We have 2 bills. We got how many bills today? 3?
About 6 pounds.
That's your committee alone.
Most of that is the housing bill. 6 members of this committee are fairly familiar with at least some aspects of that bill. Senator Chittenden is going to have a tutorial.
Outside.
From your former student.
From his former student, who will test him. But we will, I think, look at that next week so that Senator Chittenden has time to get some familiarization. And we've got a couple of other smaller bills, I think. Housing, we're just gonna look at the tax sections. There's several of them in there. Right now, we have 657 and 766. The healthcare pre-auth. We've heard from both sides. I'm just trying to get a sense, our option here, unless I can persuade the healthcare committee to go along, but they seem quite set in this bill. I'm just wondering, at this point, what's everybody thinking? Are we going to do anything with this?
I'll go first, because I think, I have a 4:30, so.
The housing bill next.
I'll just say I put a bug in Senator Lyons' ear about the 5-year prior auth for prescription drugs. That one stood out to me and felt like pretty long authorization for anything.
Talk to her about the same thing.
I'm sure they did book the bill out.
they voted the bill.
Okay,
this
so
morning.
the bug was there, but it just.
So we can, yeah, we will do a more amendment.
If. I would still want to, I didn't get a chance to hear her input because she was gonna take a second look at that provision. So maybe she did and there's more information I should know. Other than that, I find it more compelling that we would increase the standard of care, maintain a healthy workforce and reduce ER visits. By implementing this, and it may be, there may be a short-term financial impact and we are responsible for that, but I do think long-term. And even from what we're hearing, I mean, you know, with Medicare and if they all do have lower costs than patients who, you know, have higher needs, you would think that utilization would have gone up in the pandemic. And I find that the only sort of real data we have to work with to say that there's more compelling reasons to reduce this burden on our healthcare providers, and I would support the bill almost as is.
How do we measure whether or not we've actually accomplished anything or made it worse?
Perhaps reduced ER
I
utilization.
guess one question is there an accountability measure that could be imposed on whatever solution we do? So that we can look back within a reasonably short period of time and know, did this work? Whatever we do, including nothing.
Provider and insurer and reports. So we are gonna get reports from providers and from the insurance companies. And they do have to go before the Green Mountain Care Board and present. And this won't. I guess this.
The only study we do have
It doesn't have to go in the care plan.
is.
I'd like to just take another look at that account. I'd like to take another look at that reporting process.
Okay, well, we're gonna have to do it and. Yeah, that part we haven't gone over at all, we've just been stressed.
I think it's critically important, you know, when we,
Yeah.
in terms of what we do, which is financial in nature,
Yeah.
the impact of it. We need to, because we have testimony that is absolutely conflicting one with the other,
It is.
absolutely conflicting.
I can go next. Healthcare is my weakest subject area, so I'm learning these codes as we go along. I'll say I do have concerns that this is going to increase healthcare costs, which continue to keep skyrocketing. And I just remember Andrew Garland's testimony yesterday. He opened up, if you recall, big claims require big evidence. And what I'm asking for, and I did send a follow-up email, is I really want to see evidence that these changes will in fact increase total cost to the system, the average healthcare bill by 5 to 7%, which is what he made. So I'd love to see that breakout and to justify it.
Still trying to find, I know, Zane, did you get the link to the Massachusetts study?
I don't know what Massachusetts study you refer.
Well,
Blue Cross Blue Shield.
No, it was the Cygnus study.
No,
And she said there was one on doing away with all pre-auths in Massachusetts. And the woman from Cigna, right? Yeah, Cigna was up there, mentioned it, and I asked her if she would send that to us.
yeah, I do have it, yes.
Okay, how many pages is it?
Just show them up.
5,
Oh, so can we get that printed for tomorrow and
yes.
everybody can read it?
Then my other residual question on this, and if we don't have the bill, maybe this is moot, is will we be the first state to limit or align our pre-authorizations with Medicaid? And if so, why haven't other states done it? And I'm worried about us getting out in front of this if I don't fully understand the healthcare system enough to know what this could negatively impact, but I can see Sarah Robbinsdale's inching out the doors.
Well, insurance companies know we are the first.
I don't know of any state that's done it.
Yes. It's not
30
the two
is there.
Oh, 30 pages. Okay, send it to us on our. Thanks, we can.
It has already been sent out.
Okay, it's under yesterday,
At 4:51 p.m., yes.
yesterday, okay. So it is on our documents from yesterday, we can read that, we can revisit it tomorrow. Next, 6:57, Section 1, I assume, unless we go with Senator Renner, is going from the 2.4% for voice, which is now decimal dust on your phone and usage, to a 7 cent a month fee. That one, there doesn't seem to be any controversy over. That'll get us the money to get E911 in the red. In the black, sorry, but in the red display. That'll get them out of the red. The second section. I think we need to do some fine tuning, and it isn't here. We need to, I think, limit that, what's included in the property tax as started doing that stop. We need to get property valuation back tomorrow to ask what's the difference between book value and market value. And we need to make a decision about these two small munis who are doing a gross receipts tax like the railroads. And it could be a very expensive change for them to go to fair market value of their lines. And I remember having the discussion with them. They had one house that was 10 miles out and they were going to get to them. And I assume they have, but that means they've got 10 miles of line going to one house. And I'm assuming Thompson is probably it's a little town down here. It's near where they did Beetlejuice. Next door. But think about that.
Think of the carbide, well, exception based on size or something like that.
I think, if the rest of them have been paying have been paying on their lines and poles, I don't want to touch that, but I think we can leave it. I don't have to have 100% consistency. But no, we're just, yes, we do. We're not doing anything, so Jen can go home.
All right.
At least we are not doing anything at this point. We're going to read the Massachusetts study on doing away with all prior approval. I think Massachusetts study, just by a number they got thrown out, is where the number 12 to 13% came from. This is only partial, and the numbers I heard yesterday were 5 to 8% increase. But what I heard is no one has done an actuarial study on this. It's an estimate, guesstimate, so we don't know the overall. So Maria, we're just talking about where we're gonna go.
Let me know.
I think the first section is okay. There's been no controversy about that. It'll cost families with 3 and 4 lines 20-some we have 3 lines, it'll be 21 cents a month. Probably not exorbitant. And after that,
So Representative Sims emailed me earlier asking, these are things that I pencil marked for items.
Okay.
Should I go through them?
Sure.
So I don't think there should be any surprises. One is for section 2, the second block, this dropping distribution hubs, splitters, switching equipment, routers, servers, power equipment, and other network equipment, and Jill Reddick.
That was Jill Reddick's request, so we put a period after towers.
Some machinery.
And machinery.
Okay.
Yep.
Machinery.
It's what we're gonna tax and make it a property tax.
Okay.
Beyond that, she felt we were not equipped to do it.
I sent an email to State yesterday. We haven't seen language on this yet, but to address the concerns raised by the listers, anything that would clearly articulate that grievances would go through the current process to PBR and however that would be formulated to allay their concerns.
Yes.
Did you get anything back from them? I looked in just Title 32, it's not a tax attorney, but I think it would be the typical process, but I think if I understood Jill correctly, she said that they get involved themselves earlier,
Yeah.
but that you might have to start at the local level to make an initial determination. Did you actually apply what was in the, right?
Oh.
Is the property there? Did you apply what the state said? So I think maybe it would have to be
Okay,
the
can
local
you-
start, but then.
I
then
think they just
PBR
want to
would-
guarantee that when this
Yeah.
goes to court,
Yes,
if the state is gonna defend it, you may
Correct.
contest it.
I think that's what would happen, because
But,
they determine the value, so
Right.
that's,
yeah, the
So I don't-
town just can't defend it, they didn't do it.
and maybe I'll circle back with Jill and just say, is there additional language to
Yeah.
I hear that term belt and suspenders. so-
clarify?
Yeah,
Okay.
I think it would give some surety to the listers. Not that they don't trust us completely.
Two more items, these are on 13A, so one, consolidated communications, I think we mentioned this and it seemed to resonate, and also I would just say we're going in conversation with V-Trans, pushing the date out a year, right now, I believe both the inventory would be due on January 1st, 2025. Which if this goes into effect July 1st, which I think it does, that's 6 months. So if you push that out a year, what I like about that is it would give everybody the full, all 4 seasons,
Yeah.
because there's like things you do in the spring, which is when you can
Some
combine.
places you can't get to in the spring and some places you can't get to in the winter.
And then that means pushing out the
Yeah.
report and also the assessment of a full year
Yeah,
as well.
because they're gonna have to coordinate probably with the state to find out where the center line is, so they can measure and find out where their poles are, or whether they're in the right of way, so. Yeah, I think at least a year and.
So can I just clarify, so the collection would begin July 2026, full year out. The collection of the fee
Okay.
collection, right? Then the inventory. That the providers have to submit, right now it says January 1st, 2025, so you're saying July 2025 or,
No, January
oh, 2026,
6th.
got it, okay,
Okay,
okay. Got it.
And then the fee would be the year from whatever it currently is as well, so just basically adding the year to the dates.
Yeah. Okay.
The last one is the most prudential, but I have to advocate for my
Okay.
constituency,
Okay.
and I think there's an argument. So this rate structure proposed by that house has a rate that would county based. Basically, Chittenden County fall into this one category, and it has to do with population density, but there are very rural parts of Chittenden County. I'll take you to Bolton, I'll take you to Westford, I'll take you to Underhill, I'll take you to Huntington, and so
Yeah.
my concern is that those areas need these services as
well,
well.
I was surprised that Franklin said they were in the 7-cent bracket.
Yeah. I think Franklin County might have been in that mid-range.
Well, it may be getting lumped in with Chittenden because they're in the same federal. So I think I'd like to look at those rates and before we make the final decision. And
I don't want to reinvent the wheel, and that's why I did CC Michelle Boomhauer, because I feel like there's a classification of our state roads, and when there's a population density of a certain amount from a mile, it's like a transportation corridor of sorts, and so I'd support a higher rate when there's more people that live near a right of way, because then you've got the economic base to support the higher rate. And then have it just be for the state roadways where there's less people within a mile or so, then you can have those 3 tiers, but I just wouldn't do it in the county, because then we're gonna still disadvantage rural people that need.
Absolutely. I think that makes a lot of sense.
Along those lines, actually, Ted brought up a good idea, and I don't know how hard this would be, but trying to capture more granular, maybe looking at census blocks or
Sure.
because the getting the population, not just is it a municipal road or a state road, is it can. So I don't know, so maybe there's some census data. But we'll explore that further, try to come up with some population based.
Yeah.
Granular you are, and what public affairs you are, you're always gonna have that situation where it appears to be more dense, but there's still that house that's
10 miles
the
out.
end of the 10-mile gravel road.
Yeah. Okay. I think that's what I've heard. I know there's been some issues. Yeah, make sure we're gonna. Okay, we took that out. My notes. They're adding the Vermont suicide crisis line. And it's something about if there's enough money. We haven't talked about that, Maria. They're adding a new program to be paid out of the Universal Service Fund. But
Yep, they are, and I think the way it's
if
written,
insufficient funds exist,
well, the way the language reads is the fiscal agent shall pay for this program within annual limits approved in advance by the General Assembly. So you'll have a review. I think part of the issue with 980 is they've had some federal funding, which is going away. So they have asked for general fund dollars. This is an attempt to, on a sustainable going forward basis.
you say we will fund them.
But you will have the final say on how much of this fund they will receive. I don't know. I honestly don't know what their budget is or how much they might look.
Bill is going to approve.
Probably has appropriation in it.
Okay, that's right.
Has the $150,000.
Okay, so we don't have to worry about that section. Of course we'll deal with that. Going through my notes again. Yeah. Personal. Utility cable lines and poles.
Can I ask a question?
Yes.
This is just clarification because it did come up a couple of times and I'm not sure what the intent is. So for the right of way tax and the submission of the inventories.
Yeah.
So there are exemptions for who actually pays the tax, right? CUVs, the small carriers, the cable companies, the electric companies. The question is, for the inventories and the collection of that data, who submits that? Who would you like to submit that?
I would assume the companies would take.
I think that might be how I interpret it, but I don't think it's clear. So I just wanted to.
Is that who we want? I mean.
Because there are two things going on. There's the question of.
Is AOT gonna finish this? AOT has done a lot of work.
Well, that's part of the question is there's the submission of the data specific to collection of the fee, and then there's submission of data for broader state purposes, understanding what's in the right of way, even if it's not assessed. So that's the policy question, but those are.
Does the language currently read that the exempt organizations don't have to submit the inventory, or do they?
So it says, communications providers subject to subsection B of this section. Which subsection B is where the fee is assessed. So I read that as just those companies who have to pay the fee, but I don't think it's clear. So, and anyway, it has come up a couple of times, so regardless, it may be a little clarity.
Yeah, because CUDs are stringing a lot of line. They're exempting them, but other than people seem to think we can fund most of state government on this fee. That the reason I've heard most is that we should know what's there. And I think.
Before we start cutting like 5 years.
Well, we should know just in general, what's in the state right of way. So if we've exempted a lot of organizations, so we're gonna have a big hole if our purpose is to know what's in the state right of way, if we don't know whose CUD lines are in the state right of way. Or if most of them are being hung on somebody else's poles, but I think they're putting up some of their own. So, and we've got Franklin Telephone.
Right.
Who's,
This might.
yeah, no, I mean, they've got lines. We may exempt them, I think they're exempted from the fees. We should know how many lines are strung up there on the Canadian border.
Only because I've heard Rob White testify on this probably 5 times. I would say I'd be more inclined to honor the language as is, only to work the kinks out of this. So if we have a fewer subset that have to work through this rather than everybody under the sun, they are very worried that this is just gonna be really difficult knowing where the lines are. So maybe it's better that it's only to those that are expected to pay the fee, then it could be expanded later. If you change your mind in 5 years and want to start taxing CUDs, causing people consternation in the room, I'm guessing that's safer.
Okay, that, yeah, I would like to respect what V-Trans has done. I think, you know, the pole owners may have to go up there with them, but I think they're gonna have to be there because they're gonna have to decide where the center line is. Some of these old roads, it may not be that easy to determine. That may be. Okay. Yes.
Worried about. I don't think we ought to be exempt, deciding who's exempt and who's not exempt before we find out what's out there. And that's what has been unsettling to me about the bill that came from the.
Would take the fee out and wait. I mean, the fee is there right now if we go into the transportation fund, but it hasn't put any money in. And I don't think it's gonna produce enough to save the transportation fund. So we could just say, we're gonna do the inventory, and once we get the inventory, then we'll decide what we do with it. The issue has been, we put a tax on it, and a fee, and it hasn't been collected. You listen to V-Trans, say it's more trouble than it's worth. I've heard cost benefit several times. So that is an option.
I kind of like that, we're pushing it out a year, taking the fee away, just charging, maybe taking exemptions out and just asking for the inventories.
Okay, yeah, that would be a place to start. We should,
These seats next year and figure out what to do next.
you're gonna leave this municipally owned out.
If it's out there, let's count it. And then after we learn what's out there, decide
Well, I think
what the policy should be based on what we've learned.
we'll have to hear from the CUDs if we're include that. They definitely are part of what's out there, a big part of what's out there. And we should hear that, so we'll ask Ron Fish to come in. Or Christine, whoever they think is best, FX. Bring everybody in and see what this would do to them if they're newer, they may know now what they're putting in the public right of way, so we'll see if that's.
Same, well, everything, you know, they were using the poles and wires on one cross lots,
Yeah,
which is not in the right.
right,
So it,
now, right of
We
way
don't know.
is so many feet from the center line of the road, unless there's other right of ways. Okay. So we'll see who we get in tomorrow. The Yale bill is also headed our way. We got, I believe, today, the Medicaid flip bill with the increase in the corporate tax attached. I've been told that program is going in the budget with the appropriation that the budget can afford, and I'm planning on just leaving the rest of the bill on the wall. So that's why we will get it up there. I think that's it. Next week, if we can get a walk through the tax section for the housing bill tomorrow, that would be Kirby and the tax commissioners told us in the bill as it's come to us are the property tax value increases for a variety of programs done in different areas. That wasn't in the Senate bill when it came out. It is in whichever bill this is. I think it's a House bill we're attaching all four bills to. There are some other tax things in there. We could go through the entire 5-pound bill. But that there's two committees that are already working on it and negotiating on it, and I'm just soon we not get in the middle of that fight.
I'll do my homework.
You can skip me.
I can't remember the breakout, but besides, Mr. Keaton, there was also Mr. Gray. Exactly, so maybe it's not a finance committee, Tom Gray.
Oh, John Gray. He did a lot of the policy stuff, I think, for us. I don't think
Yes, I don't
he did in
remember.
taxes.
Well, I was just, there's the 311, once we got past that 250, and some municipal stuff, then we only got a quick walkthrough from that. Mr. Gray, Mr. Keaton, and I don't remember who did exactly which pieces.
I think it's Kirby that would be doing the taxes, and it's probably the tax commissioner who will be advocating for them. I think there's some downtown tax credit changes or changing use kinds of things. So we'll look at that and we can get that set up for tomorrow. If we can, Kirby, tax commissioner, that should do it. And we might be able to get that one out of here because I was told we should start on the yield bill, as early as tomorrow before we get it, even though I'm anticipating it's likely to get decorated on the floor. But we're probably gonna spend most of next week there, and I'd like to clean up the rest of these things. So, I think that.
I'll need some help from many members after Friday afternoon. I'm gonna miss tomorrow afternoon.
Oh, okay.
So I'll need some.
The tax things are pretty simple. I don't think you'll have a hard time.
I'm planning to zoom in like 1 to 3, but I.
Okay,
But
so
then I-
we can do that. Okay. And things, unless anybody else has something. Read the, yeah, well, you've got two studies to read. I hope the one from SI, if it's a medical study, it's gonna be long. Oh, it's 30 pages. It is. That's why we're not printing it out for you. Read it on the computer. Okay, that should do it.